Usage and awareness of nutritional screening tools by nurses caring for pediatric patients in Yozgat Province. Kubra Tasdin, Yesim Andran Sanali Zainep Sisik. Introduction. The development of children's nutritional skills can influence their optimal nutritional status, and deficiencies in these skills may lead to chronic diseases and malnutrition in the future. Therefore, efforts are being made to assess individuals' nutritional status. Nutritional monitoring is especially crucial for diseases such as cancer. Malnutrition is a significant health issue and is closely related to prolonged hospital stays, growth retardation in children, increased complications, and mortality risk. Adverse outcomes such as muscle tissue loss, delayed wound healing, and prolonged hospitalizations are potential complications in prolonged stays and malnutrition. For these reasons, the effective use of nutritional screening tools is vital for the early detection of malnutrition. Improving individuals' health status can be achieved in this way. During the treatment of diseases such as cancer in children, the use and awareness of screening tools by dietitians and nurses are essential. Various nutritional screening tools such as STRON Kids, Pediatric Nutrition Screening Tool, PNST, Pediatric Yorkhill Malnutrition Score, PYMS, and Subjective Global Nutritional Assessment, SGNA, are used for this purpose. Some studies have pointed out that the complexity of existing pediatric screening tools poses a barrier to their widespread clinical application. Therefore, it is suggested that the validity, effectiveness, and ease of use of pediatric nutritional screening tools should be evaluated to improve the nutritional care processes in hospital settings. Based on this information, nurses caring for pediatric patients' active use of nutritional screening tools, their skills in using these tools, and their awareness about them are vital factors that can potentially improve pediatric patients' health. Studies are being conducted on the content, general characteristics, and validity and reliability of scales used to screen and assess the nutritional status of pediatric patients in Turkey. However, it should also be noted that there is a lack of data in Turkey. The aim of our study is to examine the usage and awareness of nutritional screening tools among nurses caring for pediatric patients in Yozgat Province. Methods. The study was planned as a prospective, descriptive, and cross-sectional design after obtaining permission from the Ethics Committee of Yozgat Bozok University Social and Human Sciences. Date: June 28, 2024. Decision No 15-20 seconds. All procedures were carried out in accordance with the ethical rules and the principles of the Declaration of Helsinki. A 22-question online questionnaire was administered to 94 nurses caring for pediatric patients in Yozgat Province and its districts. Data were evaluated using descriptive statistics with SPSS version 27.0. The results were discussed alongside the literature. Results. Of the participants, 78.7% were female. The group predominantly comprised nurses aged 25 to 34, 60.6%. 62.8% had a bachelor's degree. 66% worked in state university hospitals. 30.9% of the nurses had been practicing nursing for 6 to 10 years and constituted the majority. The proportion of service nurses was 78.7%. The percentage distribution of the ages of the patients the employees cared for showed similarities. These distributions are presented in Table 1. 24.8% of the participants reported having heard of the Pediatric Nutrition Risk Score, PNRS. 8.5% reported having heard of the SGNA, 17% reported having heard of the Screening Tool for Malnutrition Assessment in Children, STAMP. 4.6% reported having heard of the PUMS, 15% reported having heard of the Screening Tool for Nutrition Status and Growth Risk, SRON Kids. 9.8% reported having heard of the PNST, while 20.3% reported having heard of none of these tools. These data are presented in Table 2. 51.1% used anthropometric measurements, such as height, weight, and head circumference. For every hospitalized pediatric patient, 11.7% sometimes used them, and 37.2% did not use them at all. 19.9% used a screening scale, 25.5% used anthropometric measurements, 12.8% used biochemical findings, and 27.7% used visual assessment to determine nutrition risk status, while 14.2% did not use any of these methods. These results are presented in Table 3. 47.9% of the participants indicated that a screening scale was used to evaluate the nutrition risk status of children in their institution. 28.7% stated it was not used, and 23.4% were unsure. 1.1% indicated they used anthropometric measurements as a form, 1.1% used percentiles, 3.2% used the child health monitoring form, 1.1% used the nutrition status evaluation form, 2.1% used the child nutrition form, 1.1% used the NRS 2002 form, 4.3% used the nutrition form, and 6.4% used the STRON Kids form, while 27.6% did not know which form was used. Results are detailed in Table 3. 40% of the participants stated they used this form regularly. 1.1% did not use it due to increased workload. 21.1% did not know how to use it. 30% indicated that there was no form available. 4.4% said the physician did not request it, and 3.3% stated they did not see the need for it. Results are shown in Table 3. When identifying nutrition risks, 65.1% of the participants referred to a physician, 29.4% referred to a dietitian for intervention, and 5.6% were unsure how to intervene. Discussion. In our study, participants composed of nurses were asked about nutrition evaluation, various screening tests, their knowledge about usage, and what assessments were made in nutrition evaluation. The responses given were evaluated. Among the participants, 20 nurses, 14.2%, stated that no nutritional assessment was conducted with any application, and 52.1% of the nurses reported that there was no institutional information provided on this issue, or if there was, they were not informed about it. 27.6% were unaware of any screening tools. The most cited reason for not using screening tools was the absence of a form. Nevertheless, 95% of the nurses said there must be an intervention for patients with a nutritional problem. Various screening tools used to identify functional nutritional disorders in children are effective, and the significance of screening scales in detecting malnutrition is considerable. Some of these tools have demonstrated the ability to quickly and accurately identify nutritional disorders in children. However, it is also recognized that some tools contain numerous questions, making their use complex. Overall, research findings emphasize the importance of selecting an appropriate screening tool for detecting nutritional disorders in children for healthcare professionals. However, it reveals that these tools are generally underutilized and that more studies are needed. Our study also determined that nurses caring for pediatric patients considered the screening scale as a secondary option for identifying the nutrition risk status, predominantly performing visual and anthropometric evaluations, and did not demonstrate sufficient proficiency or importance regarding screening scales. Among the participants, 31 nurses, 20.3%, reported they were unaware of the screening tools, and 41 nurses, 31.3%, stated they did not use screening tools, which is considered a significant figure. Although it was determined that visual and anthropometric evaluations were being conducted, it was found that 35 nurses, 37.2%, did not perform anthropometric measurements. Similar findings were noted in a study conducted in Canada, where more than 50% of nurses underestimated the prevalence of malnutrition in hospitalized patients, yet 92.5% were willing to include a nutritional screening process in inpatient admission procedures. In the same study in Canada, 17% of nurses indicated that helplessness in eating was a significant cause of malnutrition, 39% reported limited access to nutrition education, and 92% expressed interest in such training. In a study conducted in Korea, 78.7% of nurses believed that nutritional management was necessary, a value lower than what we found in our study. In the same study, 34.9% of nurses claimed to have knowledge of at least one criterion for nutritional assessment, but the percentage of those aware of the normal range for body mass index (BMI) was only 0.9%, indicating a significantly low level of awareness. Our study similarly found a meager percentage of knowledge regarding screening tools and low usage rates of assessment criteria outside of the screening tools. Similar results were found in a study conducted in New Zealand. It was observed that the use of nutritional screening tools for pediatric oncology patients was limited, and dietitians had insufficient awareness and resources. Standard screening and assessment methods for detecting malnutrition were recommended. It was understood that the usage issues faced in various world regions share common causes. Another study found that pediatric malnutrition screening tools are beneficial in clinical use, but some challenges were faced in practice. Newly developed tools effectively monitor malnutrition risk, especially in children who stay in the hospital for a long time. However, it was noted that the most significant barriers faced by healthcare workers in using these tools were time, cost, and resource shortages. The importance of simplifying and integrating these tools into healthcare processes was emphasized. Another issue regarding usage is that the reliability and validity of nutritional screening tools used to identify pediatric malnutrition may vary. However, it has also been emphasized that these tools are essential for the early detection of malnutrition. A study evaluating the PYMS screening tool and STRON kids found that PYMS had higher sensitivity and specificity in detecting malnutrition risk than STRON kids. The sensitivity of PYMS was 95.7%, and its specificity was 66.7%. In contrast, the sensitivity of STRON kids was 52.2%, and its specificity was 41.7%. The results indicate that PYMS is a more reliable and effective tool for screening malnutrition in children. It is noted that PYMS is a practical screening tool and can be preferred in clinical settings, mainly due to its ability to be applied in a short time. In another study, STAMP STRON kids and the PYMS were found to have moderate validity and reliability in hospital settings. However, it was determined that tools used in community settings did not meet these criteria. The research highlights that the validity and reliability of nutritional screening tools show differences based on the users and that the tools should be standardized. As a result, it is stated that the tools used for detecting pediatric malnutrition need more validation studies. Most existing screening tools have not been tested in specific age groups or integrated into electronic health records. Tools like STRON Kids and PNST are essential for the early detection of malnutrition, but there is a need for more valid studies in younger age groups and broader populations. It is emphasized that increasing training and widespread use of the tools in clinical practice is necessary. In this context, it can be concluded that an ideal nutritional screening tool should correctly identify high-risk patients while excluding those with low risk. In another study, it was determined that both STRON Kids and PNST screening tools could identify the risk of malnutrition in children, but the initially proposed cutoff points were not suitable for the study population. In the same study, adjustments based on ROC curve analysis showed that both tools had better concordance with nutritional status assessment. When adjusted cutoff points were applied, point 12 in particular, PNST was found to have a higher sensitivity with adjusted cutoff points and was more suitable for clinical use. Both tools could assist in detecting malnutrition, but PNST was noted as the most appropriate tool with the revised cutoff points. Point 12 in another study, PNST was found to be a simple screening tool that quickly and accurately detects the risk of malnutrition in pediatric patients. Point 9 the study demonstrated that PNST showed 77.8% sensitivity and 82.1% specificity compared to the pediatric SGNA. These results indicate that PNST is a reliable and applicable option for effectively detecting malnutrition risk in pediatric hospital admissions as an alternative to the more complex existing tools. However, it was also noted that PNST has limitations in detecting particularly chronic malnutrition or overweight children. Some studies have reported positive results and a continuous increase in the use of nutritional screening tools. In a study conducted in Belgium, the STRON Kids screening tool effectively identified malnutrition risk in hospitalized children. The study determined that STRON Kids could detect acute malnutrition with 71.9% sensitivity and a 94.8% negative predictive value (NPV). The tool was also associated with the length of hospital stay, indicating that children who stayed there for 4 days or longer were at risk of malnutrition. The tool also showed a high predictive value, 98.9%, for initiating nutritional interventions. As a result, STRON Kids was indicated to be both a practical and a reliable tool for determining the risk of malnutrition in children. In a study conducted in Brazil, the STRON Kids tool demonstrated strong performance in predicting prolonged hospital stays in pediatric patients. It was found that children with 3 points behaved similarly to those at high risk with 4 or 5 points, Therefore, it was concluded that patients scoring 3 points with STRON kids in hospitals in Brazil should be considered at high risk, similar to those scoring 4 or 5 points. This is an essential step in preventing extended hospital stays and adverse clinical outcomes. A study conducted in Turkey noted that scales used for screening pediatric nutritional status may not be suitable for every patient and that ethnic, developmental, and disease-specific differences could affect the effectiveness of screening tools. In this study, it was particularly stated that scales such as STRON kids and the PYMS were widely used to determine the risk of malnutrition in children, but there were limited validity and reliability studies on these scales in Turkey. It was concluded that the simplicity and practicality of existing scales supported their widespread use in practice. The importance of education for healthcare professionals to increase the use of screening and assessment tools was emphasized. Another study conducted in Turkey used the STRON kids screening tool, which was found to be reliable for assessing nutrition risk in neurology patients. In this study, patients at risk of malnutrition were identified through screening, and opportunities for early intervention were provided. Furthermore, it was concluded that STRON kids, a simple and practical screening tool, could be widely used in clinical settings. However, it was emphasized that more detailed assessments are needed, especially for identifying advanced malnutrition cases. In another study, 302 nurses participated in an evaluation in Turkey. The level of knowledge regarding nutrition was around 50%, and it was recommended that nursing education institutions review their curricula in terms of clinical nutrition education and develop a regular nutritional education program. This recommendation is consistent with our conclusions. In cases with a high rate of underutilization or unawareness of screening tools, awareness-raising efforts should be made to mitigate this situation. For example, a study conducted in Norway aimed to evaluate the changes in clinical nutritional care after 10 years of implementing national nutritional guidelines. A study conducted in 2004 revealed that there was a lack of information about nutritional care among doctors and nurses, and inconsistencies were found in practices. A follow-up study with a similar questionnaire in 2014 showed significant improvements in nutritional practices. In a similar study in Norway, while 67% of participants identified the lack of information as a fundamental barrier in 2004, this rate decreased to 57% in 2014, p less than 0.001. In this study, findings from 2004 indicated that similar to our study, only 46% of nurses had difficulties identifying undernourished patients, assessing their energy needs, and developing a nutritional plan. However, in 2014, it was observed that 57% of the participants were knowledgeable about the topic, indicating an increase in their level of knowledge. In a study conducted in England evaluating the use of nutritional screening tools, various recommendations were made to increase the use of these tools. It was emphasized that regular routines are essential to maintain nutritional screening effectively. Most participants indicated that they developed various routines, such as conducting weekend screenings, to ensure that the screening process was not interrupted. The importance of nutritional assessment and communication with patients was highlighted regarding good practices in nutritional care. Participants noted that understanding patients' nutritional habits and developing personalized nutrition plans were critical for providing adequate care. It was concluded that nurses should have more autonomy in nutritional care. Nutritional screening is seen as a process that requires clinical judgment, and it is suggested that increasing nurses' decision-making authority will enhance the quality of nutritional care. Conclusion: it is recommended that necessary training be provided to pediatric nurses to use these tools more effectively, and that current practices be reviewed. This will enable better assessment of the nutritional status of pediatric patients and the implementation of steps to prevent malnutrition. It is stated that there is a need to increase awareness of nutritional assessment in human resources to ensure the use of the mentioned tools, and steps should be taken to promote the more widespread use of screening tools as indicated in the literature.